Everyone, we'll be discussing the surgical anatomy of facial nerve today. I'm Dr. Neha Verma. I'm working as assistant professor in Department of ENT at UCMS and GTB Delhi. Um, First of all, the question comes, why should we know the surgical anatomy of the nerve so importantly? See, the anatomic structures take on different spatial perspectives as they are approached from different angles. So form the facial nerve proper. The nerve consists of a total of around 10,000 to 12,000 fibers, which are myelinated axons, of which 7 to 9,000 are in the motor root of the facial nerve and 3 to 5,000 are in the nervus intermedius. Both the nerves, that is, uh, the first slide basically was about the composition of the nerve. And as I had said earlier, the facial nerve consists of a motor root and a sensory root. The motor root carries the motor fibers to the facial muscles, whereas the sensory root carries taste fibers from the anterior two-thirds of the tongue. These two together, they unite to form the facial nerve proper. The facial nerve consists of a total of 10,000 to 12,000 fibers, of which are the myelinated ones. Of these, 7,000 to 9,000 are in the motor root of the facial nerve and 3,000 to 5,000 are in the nervus intermedius. Both these nerve roots also contain some unmyelinated axons. The facial nerve also has several parenchymal elements, that is, being a mixed nerve, it carries some efferents and gives away some afferents. So the somatic visceral efferents are the motor axons supplying the facial muscles. These are very important. And then the special visceral afferents are the fibers carrying taste sensation from the anterior two-thirds of the tongue. The facial nerve arises from several nuclei because it is a motor nerve, and any of this nucleus may get damaged at a cortical injury and affect the function of the nerve. The facial motor nucleus lies at the pontomedullary junction, just behind the trapezoid body and deep to the trigeminal nerve root. It lies medial to the spinal trigeminal nucleus. The superior salivatory nucleus is the one which provides parasympathetic fibers of the facial nerve, which continue in two pathways, that is the lacrimal pathway and the submandibular pathway. Then there is the solitary nucleus located in the medulla. This innervates the taste buds in the anterior two-thirds. So the taste sensation is relayed into the solitary nucleus, whereas the sensory fibers from the geniculate ganglion carrying sensations from the posterior surface of external ear are relayed in the spinal trigeminal nuclei and tract. So this diagram shows you the craniocaudal arrangement of the various nuclei and the fibers that are provided. We will discuss about the nerve anatomy next. The facial nerve for surgical purposes is divided into several segments. There is the intracranial, intratemporal, and extratemporal segment. For otolaryngologists, generally the intratemporal and extratemporal segments are important, but many of us will go on to become neurootologists, so we also need to know a bit about the intracranial segment, which constitutes the pontomedullary segment, the root exit zone segment, and the cisternal segment. The intratemporal segment is divided into the meatal, the labyrinthine, tympanic, and the mastoid segment, whereas the extratemporal one is divided into the facial nerve trunk and its peripheral branches. This is just a brief that the facial nerve fibers are represented at the cortex in an arrangement where the eyebrow fibers are superior to the fibers of the eyelid, nares, and lips. And this representation is carried on throughout the corticobulbar tract and internal capsule, only to decussate at the level of the facial nuclei at the pontomedullary junction. So whenever there is an upper motor neuron lesion, the face is protected in its upper half, that is the eyebrows and the eyelids maintain and continue to have their function. The pontomedullary segment of the facial nerve starts from the facial motor nucleus, where the fibers arise, and the nucleus basically is around 5 millimeters from the midline. The fibers arise from it and they circle around posteriorly around the abducent nucleus. So the fibers from the motor nucleus located anteriorly go behind towards the abducent nucleus, circle around them, and then come out again towards the anterior part. Now this turn is called the internal genu of the facial nerve, and in reality this is the real first genu of the facial nerve. However, for otolaryngologists, the first genu surgically would be discussed at a later stage. These turn of the fibers, they give rise to a structure or the round eminence in the floor of the fourth ventricle that is called the facial colliculus. As you can see in this diagram, this is the posterior surface of the pontomedullary region, and the bulge just next to the midline. If you can see here, this is the midline, and the bulge over here is the facial colliculus. From here, the nerve turns anteriorly and exits the pontomedullary junction at the root exit zone, and this is called the root exit zone segment of the facial nerve. This is the area where the nerve emerges from the anterior surface of the brainstem and is constituted by a root exit point, an attached segment, a transition zone, and a root detachment point. Now coming on to the root exit zone. The facial nerve arises from the lateral end of the pontomedullary sulcus. Now, if you notice this yellow arrow, this is the pontomedullary sulcus, and its lateral end arises the facial nerve. The facial nerve here is shown in red, and the vestibulocochlear nerve is shown in green. The facial nerve is 1 to 2 millimeters superior to the point at which the vestibulocochlear nerve arises. Now, the facial nerve is located anterior to the choroid plexus, just where the choroid plexus is just protruding from the foramen of Luschka. To understand this, let's see the inset in detail. So, just follow my cursor. This is the facial nerve. This is the vestibulocochlear nerve. Posteriorly is the cerebellum. This is the flocculus and choroid plexus along with the foramen of Luschka highlighted in blue. So the facial nerve is superior to it. Also, the facial nerve is superior to a line joining the nerve rootlets of the 9th, 10th and 11th nerve. As you can see here, the blue line, the facial nerve lies above it. It is also slightly posterior to the inferior olive. And this portion, just at the rootlets of the lower cranial nerve, is the inferior olive, and the facial nerve lies superior to it. Coming on to the definitions of the various parts of the root exit zone segment, the root exit point is the intraaxial facial nerve, is a point where the intraaxial facial nerve courses through the pons and exits the pontomedullary sulcus. The nerve does not detach itself completely from the pons, but remains strongly attached to the pontine surface, and this is termed as the attached segment in the arrow yellow. The root detachment point is where the facial nerve separates from the brainstem. There is a transitional zone, also termed as the Obersteiner-Riedlich zone, where the central myelin changes to peripheral myelin. The transitional zone is thought to lie somewhere 2 to 3 millimeters from the root exit point. So around here would be the transitional zone. It is important to know that any systemic disorders affecting the central myelin or the peripheral myelin both may affect this region and affect the function of the nerve. Now we come on to the important segment, that is the cisternal segment, important to those who are doing uro-otology. The facial nerve continues with as two roots within the cerebellopontine angle, as you can see in the diagram above, as well as the endoscopic image below. The facial nerve is very close to the cochlear nerve. This is the facial nerve, and next to it is the cochlear nerve. The nerve courses anterolaterally and superior to the vestibulocochlear nerve towards the internal acoustic opening. This is the opening of the internal acoustic meatus. So from the pontomedullary junction towards the internal acoustic meatus. It measures around 23 to 24 millimeters. An important structure, the artery, anterior inferior cerebellar artery, it starts deep to these nerves and courses superficial to it, arising in between the two. Now, the important part here is that this artery may sometimes loop around the facial nerve rather than going from deep to superior, and it may compress the facial nerve, and this leads to the hemifacial spasm and tics in the facial motor muscles. Now, a brief about the sensory root. In the cisternal segment, the nervus intermedius or the sensory root lies between the facial motor root and the superior portions of the vestibular nerve. It is intimately attached to the vestibulocochlear nerve initially. It only passes towards the facial nerve as the nerve approaches the internal acoustic meatus. Often it is seen as more than one filament, but in around 20% of the cases, when we are operating in the cerebellopontine region, we may not be able to identify a separate root as it is intimately attached to the vestibulocochlear or the facial nerve. This diagram again shows the same. This is the vestibulocochlear nerve and this is the facial nerve. So initially, the nervus intermedius is very close to the vestibulocochlear nerve and only gradually goes on to join the facial motor root and form the facial nerve proper as it enters into the internal acoustic meatus. The nervus intermedius has no branches to any terminal structures, but forms multiple connections to the surrounding vestibular nerves and the cochlear nerve. So, even despite damage to the facial nerve, you may still maintain some of the sensory functions slight bit because of these interconnections. Now we come on to a very important segment called the meatal segment. This is the part of the nerve where the nerve runs within the internal acoustic meatus. Now, to understand the course of the nerve, we have to understand what is the internal acoustic meatus. This is a funnel-shaped structure which begins at the internal acoustic opening. As you can see here, this is the internal acoustic opening or the porus acousticus and ends at the fundus of the internal acoustic meatus. This canal is located in the lateral part of the meatal depression. The petrous bone has a depression on its superior surface which is bounded medially by the trigeminal nerve impression and laterally by the arcuate eminence of the superior semicircular canal. And this meatus lies in its lateral part. The porus acousticus or the internal acoustic opening lies at a point which is midpoint over the line joining the base of the petrous part of temporal bone to its apex. So this line joins the base to the apex and at its midpoint lies the internal acoustic meatal opening. The total length of the meatus is 8 millimeters. So facial nerve also is around 8 to 10 millimeters. This is a funnel-shaped structure such that the porus is wider than the fundus. The roof of the internal acoustic meatus gets thinner as we move towards the fundus. So when we are approaching the facial nerve from a middle cranial fossa approach, it becomes more vulnerable because the roof becomes thin. As you can see here, this is slightly thicker at the internal acoustic meatal opening and becomes thin towards the fundus. Now, the facial nerve transitions in its position such that initially in the cisternal part, it was inferior and anterior to the vestibulocochlear nerve. But as it reaches the fundus, it becomes antero-superior in position. So from an antero-inferior position, it comes to lie antero-superiorly. The nerves of the internal acoustic meatus are all surrounded by dura all the way to the fundus. So all the meningitis may affect the function of the facial nerve. The lateral end of the internal acoustic meatus is divided into a superior and inferior half by a transverse crest called the falciform crest. It is also divided into anterior and posterior part by a vertical crest, which we will also deal in detail in the next slide. These together divide the fundal end into 4 quadrants, and each quadrant being occupied by one nerve. So 4 quadrants, 4 nerves. And the representation of these nerves can be understood in this simple diagram, where the falciform crest is the horizontal division and the vertical crest is the Bill's bar, dividing into 4 quadrants. The facial nerve occupies the antero-superior quadrant. The cochlear nerve occupies the inferior quadrant, and the posterior half is occupied by the vestibular nerves respectively, such as the superior vestibular nerve in the postero-superior quadrant and the inferior vestibular nerve in the postero-inferior quadrant. Now, to remember this, there is a simple mnemonic called 7-up. We've all had this cold drink, 7-up. So the 7th nerve is up and it's always anterior. So it's easy to understand. 7 is up, cochlear is below, posteriorly are the vestibular nerves, superior and inferior respectively. Now the Bill's bar is the vertical crest that we had discussed earlier. It is named so because of the person who described it first, that is Dr. William House. It divides the area above the transverse crest into an anterior facial canal and a posterior superior vestibular area occupied by the superior vestibular nerve. It lies at the upper edge of the meatal fundus. However, it is not a vertical plate, but is actually triangular in structure, having its base located laterally. As you can see in this image, the asterisk marks the Bill's bar, and it's a triangular structure with its base directed laterally. What happens is, because of its triangular structure, the nerves move apart from each other as they move from medial to lateral. So the facial nerve diverges away from the superior vestibular nerve. And this is a very important landmark for locating facial nerve when we are operating in the meatus or via the middle fossa approach. Then comes the labyrinthine segment of the facial nerve. This is so named because of its intimate relation to the labyrinth, that is the cochlea and the semicircular canal. So this is the cochlea anteriorly and the semicircular canals located posterior to it. This portion of the facial nerve lies just proximal to the ganglion and is the shortest segment of the facial nerve, measuring only 3 to 5 millimeters. From the fundus, it starts from the fundus of the internal acoustic meatus and ends at the geniculate ganglion. Now in this image, we have uncapped the fundal area. So the true length is only this much from the fundus to the geniculate ganglion, very short. At the beginning of the first portion of the facial canal, there is a slight constriction from the vertical crest. And at this point, the nerve is covered only by the pia and arytenoid membrane because the dura has already terminated at the fundus. The periosteum of the internal acoustic meatus at the fundus is very thick and it forms a constricting ring around the facial nerve. The nerve here is very small in diameter. It is the smallest diameter of the entire facial nerve segment and it measures only 0.68 millimeters in diameter. Also to notice that it occupies 80% of the facial canal volume and in the labyrinthine segment. So It has very small area to expand in cases of any inflammation or swelling of the nerve and can easily get compressed and lose its function in this segment. Now, as I said earlier, the cochlea lies in front of the labyrinthine segment and the semicircular canals are posterior to it. This segment lies parallel to the superior semicircular canal, that is forming the arcuate eminence when seen from the middle cranial fossa. It also has an angle of 90 degrees from the longitudinal axis of the internal acoustic meatus. The clinical consideration here is that the facial nerve is most constricted at this point, and one must cut this constricting ring of periosteum to decompress the nerve. Otherwise, a very appropriately performed surgical decompression may still fail if you fail to cut this constricting ring. Then comes the geniculate ganglion. Geniculate ganglion has been named from the Latin word geniculum, which means a joint or a knee. So this bulbous appearance in the facial nerve course is a geniculate ganglion, which joins the intrameatal segment to the tympanic segment. It is located between the cochlea medially and the tympanic cavity laterally. It also lies at the level of the uppermost portion of the cochlea. That is, the cochlea is inferior to it, and the geniculate ganglion is in close relation to the floor of the middle cranial fossa, lying just below it. The semicircular canals lie posterior to it, and the internal auditory canal is at a level which is inferior to it. That is, the labyrinthine segment of the nerve rises also a little superiorly to end in the geniculate ganglion. It is a bulbous enlargement of the facial nerve and a very important structure because it has cell bodies of sensory fibers that course through the ganglion without synapsing into it. It is richly supplied by the petrous artery, which is a branch of the middle meningeal artery arising from the maxillary artery. The petrosal artery gives 1 to 3 twigs on its surface, which forms two plexuses, one superficial and one deep. Therefore, the geniculate ganglion has the richest microvasculature in the intratemporal portion of the facial nerve. This is also prone to dehiscence, and this is characterized by the absence of osseous covering of the facial canal at this region, which may occur into 14.5 to 30% of the adult patients, prevalence being higher in children. So it has been hypothesized that the bony canal undergoes osseous calcification like other bones in the body, and any failure in this process will lead to dehiscence. The clinical considerations are that if you embolize the maxillary artery for any epistaxis or any anti-cancer drug treatment through this artery, you may end up with a facial palsy. Because of its rich blood supply, it's also a site for hemangioma, which you might have to operate upon at some point of time. The dehiscence of geniculate ganglion makes it very vulnerable when you are approaching the facial nerve from a middle cranial fossa route. The peripheral facial palsy may occur because of injury at geniculate ganglion, leading to loss of sensory function of the auricle, reduced lacrimation, reduced gustatory sensation, and reduced secretion from the nasal and palatal glands. It is also a site of ganglionitis because of the varicella zoster virus leading to geniculate neuralgia. Now, this gives rise to three main branches: the greater superficial petrosal nerve, the lesser petrosal nerve, and the external petrosal nerve. The greater superficial petrosal nerve is the terminal part of the nervus intermedius, which emerges from the ganglion just medial to the arcuate eminence. See, if this is a superior semicircular canal giving rise to the arcuate eminence, the greater superficial petrosal nerve, GSPN, is medial to it. The lesser petrosal nerve arises lateral to GSPN and carries preganglionic parasympathetic fibers to the parotid gland. Then comes the external petrosal nerve, which is a thin nerve lateral to both these previous nerves, carrying sympathetic fibers from the middle meningeal artery. The GSPN is a very important nerve, and it passes through its canaliculus anteromedially beneath the dura. See, from the ganglion, it leaves the temporal bone and enters into the cranial cavity just beneath the dura. It runs along the junction of the petrous apex and sphenoid bones. It lies superior and slightly anterolateral to the horizontal segment of petrous carotid artery, which I'll show in the next slide, and joins the deep petrosal branch of the carotid sympathetic plexus to form the very important nerve of the pterygoid canal, or the Vidian nerve. Now here in these diagrams, the IM has been uncapped, that is the meatus has been uncapped, and you can see the facial nerve, the geniculate ganglion, and its branch, the greater superficial petrosal nerve, leaving the temporal bone. And this nerve is very much parallel to the horizontal part of the carotid artery. Now this nerve forms a very important cochlear angle, that is the angle between the long axis of the labyrinthine segment of the facial nerve. As you can see in the image on your right, this is the facial nerve labyrinthine segment, and this is the GSPN. So it forms a cochlear angle between the two, and just beneath this is the cochlea. So you can approach the cochlea by approaching this angle between the two segments and do a cochleostomy when approaching the middle fossa approach. The GSPN is vulnerable to location in the surgical field during dural elevation while we are retracting the brain by electrocoagulation, bone drilling, or inadvertent traction of the nerve. Now we come on to the most important part for us, which we understand in the daily otolaryngologic considerations. This is the tympanic segment. Now this begins at the geniculate ganglion, which is also known as the first genu. So for us surgeons, this is the true first genu, whereas the internal genu is in reality the first genu of the facial nerve. The tympanic segment ends at the level of the stapes, and you can see the nerve being highlighted in orange here. The labyrinthine and tympanic segment, they intersect with each other at an acute angle, which is usually not less than 75 degrees. The nerve, from its anterior course, as you can see here, the labyrinthine segment was directed anteriorly. The nerve suddenly shifts abruptly posteriorly and slightly laterally. It runs lateral to the vestibule and between and the tympanic cavity laterally. Its mean length is 10 millimeters. The course of the tympanic segment is such that its initial part lies anteriorly and above the semicanal for tensor tympani. If you see, this is the semicanal for tensor tympani muscle, and the initial part of the tympanic segment lies just above it, superior to the processus cochleariformis. This is the cochleariform process, and the nerve lies above it. It passes posterolaterally inferior to the lateral semicircular canal. As you can see in the arrow, the lateral semicircular canal is superior to it, and the nerve passes posterolateral to it and just above the oval window here. As you can see here, the oval window is covered with the stapes, footplate, and stapes ossicle. It follows an oblique course, as you can see with the lines indicated, and inclines inferiorly from the plane of semicircular canal in 80% of the cases. So the lines are not exactly parallel. However, in 20%, it may be so. Another diagram which represents this angulation much better is here, that the tympanic segment, it deviates inferior to the plane of the lateral semicircular canal. Now, the nerve tympanic segment lies close to the pyramidal eminence, which is situated just inferior to it. So the tympanic segment of the facial nerve is above the pyramidal eminence. From here, the nerve again takes another sharp turn of 90 degrees to form the second genu of the facial nerve. As you can see over here, it goes downwards. At the second genu, the mastoid segment starts, which we'll discuss further. The second genu is most susceptible to iatrogenic injuries, especially by young, inexperienced surgeons. So clinical considerations. this is very important to understand. The tympanic segment lies 2 millimeters superior to the cochlear process, right? Then it lies 2 millimeters inferior to the lateral semicircular canal. The tympanic segment distal end lies just above the pyramidal eminence, and the second genu is 4 millimeters posterior to the oval window. So if we keep these in mind, we can always easily decompress the facial nerve. Mind you, the facial canal is abutting all these structures. However, the tympanic segment of the facial nerve occupies only 64% of the area. So you can safely drill out while decompressing if you remember these millimeter directions. Again, the slide shows the same relationship in the CT scan. It is important to hear this. The CT scan shows only the initial part of the facial nerve, as most of the facial nerve is overlapped by the semicircular canal. As you can see here, the facial nerve is under the lateral semicircular canal in most of its tympanic segment. So it is usually not seen so well on the CT scan. Now we come on to the mastoid segment of the facial nerve. At the second genu of the nerve bends around 90 to 125 degrees from its posterolateral course, which marks the beginning of the vertical or the mastoid segment. This then moves downwards and exits the temporal bone at the stylomastoid foramen, which lies at the anterior end of the digastric ridge, which I'll be showing you shortly. The segment has its concavity, which corresponds to the posterior-superior region of the tympanum. As you see the arrow here, the concavity is very similar to the concavity of the tympanic cavity. The pyramidal eminence is located anterior to the superior or the proximal end of mastoid segment. This is the longest part of the intratemporal facial nerve and measures around 15 millimeters. Again, see here, the short process of incus is highlighted in a red asterisk, the second genu in the black asterisk, and you can see the angle that the tympanic and the mastoid segment of the facial nerve form. And from here, the nerve descends downwards, taking a concavity which is reflecting the concavity of the tympanic cavity. This is a busy slide, but I'll explain each and every sentence. The superior half of the mastoid segment rarely deviates from its vertical course, so it's very much fixed as a landmark. The mastoid segment, however, deviates posteriorly as it goes down by an angle of 5 to 35 degrees. As you can see here, the blue line represents the vertical plane, and as the mastoid segment of the facial nerve moves downward, it deviates posteriorly by an angle of 5 to 35 degrees and exits the cranial cavity at the stylomastoid foramen, if you can see the arrow over here, which is at the anterior end of the digastric ridge. This is the digastric ridge, and at the anterior end lies the stylomastoid foramen. So you can always follow the digastric ridge anteriorly to find the nerve. As it proceeds inferiorly, not only does it diverge posteriorly, but also becomes slightly lateral. The mastoid segment of the facial nerve is separated from the sigmoid sinus by a distance of almost 4 to 12 millimeters, which is often occupied by the retrofacial cells. In the inferior-most segment, it, however, becomes closer to the lateral sinus and the distance remains only 3 to 10 millimeters. The mastoid segment of the facial nerve is related medially to the jugular bulb, as you can see here, and is separated in most cases by the jugular bulb by 8 millimeters. And this region is called the occipito-jugular region. However, in some rare cases, the jugular bulb may be adhered to the facial nerve. So one has to be very careful while doing a decompression. The circle highlights the exit point, that is the stylomastoid foramen. So clinical considerations, in the superior part, the nerve is closer to the posterior wall of the tympanic cavity and the styloid complex. Styloid complex is nothing but the styloid eminence and the styloid part of the tympanic part of the styloid process, that is the styloid peg. The nerve is 2 to 4 millimeters posterior to the styloid peg. So if you can identify the styloid peg, you know that 4 millimeter posterior to it will be the facial nerve. And this is very important when you are approaching the nerve through the intratympanic route. So when you're doing an endoscopic surgery through the middle ear, this becomes very important. Tympanic ring is a good landmark, and the facial nerve lies around 3 millimeters posterior to it. Now I come on to the branches of the mastoid segment. There are namely 3 branches: the chorda tympani, the nerve to the stapedius muscle, and the sensory auricular branch. The nerve to the stapedius muscle arises at the just deep to the pyramidal eminence in the posterior wall of the tympanic cavity and pierces the canal to reach the muscle. The chorda tympani nerve, it arises from the main trunk of the facial and forms a angle of 25 to 35 degrees, that is called the Plesster's chordofacial angle. The nerve then passes superiorly and anteriorly along the posterior canaliculus, enters the middle ear and traverses on the inner aspect of the tympanic membrane. Just follow the red arrow. It then passes in between the handle of malleus and the incus and exits the middle ear via the anterior canaliculus at the medial aspect of the petrotympanic fissure. It then descends vertically downwards along the spine of the sphenoid bone. The sensory auricular branch arises just proximal to the chorda tympani and is poorly described. It supplies the sensory fibers to the posterior external acoustic meatus and inferior portions of the pinna. So, as a summary, the surgical landmarks for identifying the facial nerve in the middle ear surgery are the short process of incus. The mastoid segment is just beneath it. The processus cochleariformis. The nerve lies above it. The lateral or the horizontal semicircular canal. The oval window, the pyramid, tympanic ring, stylomastoid foramen, digastric ridge, the retrofacial air cells, and the chorda tympani. Very important to know is that the processus cochleariformis is the most reliable landmark for the facial nerve during the surgery. If the surgeon remains 1 to 2 millimeters superficial to the level of lateral semicircular canal, there is no risk of injury to the facial nerve. The superior half of the mastoid segment rarely deviates from its vertical course, but the inferior may be lateral or medial to the tympanic ring level. The mastoid segment also deviates posteriorly from the vertical. So when you're doing a cortical mastoidectomy, you must be very careful while defining the anterior limit or while drilling the posterior ESC wall. The stylomastoid artery is seen in the stylomastoid foramen and if injured, may cause ischemia of the mastoid segment of the facial nerve. For facial decompressions, one should be careful while dissecting medially in cases of adhered jugular bulb. There are several variations of the facial nerve. The canal may be dehiscent. Usually it is commonly seen in the tympanic segment in as much as almost 50% of the cases. The nerve may prolapse over the stapes and make stapes surgery very difficult. It may form a hump just posterior to the horizontal semicircular canal, making it vulnerable while opening the antrum during mastoid surgery. It may also bifurcate or trifurcate, and each of these will have its own facial canal and exit through individual foramina. So injury is possible in any of these. There may be bifurcation of the nerve enclosing the stapes. So again, stapes surgeries become difficult. Very rarely, the nerve may follow an anomalous course in between the oval and the round window. This diagram shows the length of the various segments. So the cisternal segment is around 25 millimeters, the meatal around 1 centimeter, the labyrinthine segment is 5 millimeters, the tympanic segment 11, the mastoid around say 13 to 15 millimeters, and from there on it exits into the extratemporal part. This diagram shows the various angles that the nerve takes. From the meatal to the labyrinthine is 132. From the labyrinthine to the tympanic is 75 degrees. From the lateral semicircular canal, the nerve deviates downwards around 10 degrees. And from the vertical, it deviates posteriorly in the mastoid segment by 5 to 35 degrees. It's important to know that the horizontal semicircular canal itself is 20 degrees inferior from the horizontal plane. So the facial nerve in reality is around 30 degrees angulated from the horizontal plane. Now we come on to the extratemporal segment of the facial nerve. The facial nerve exits the skull at the stylomastoid foramen enveloped in a tough tissue which is called the facial diaphragm. The nerve segment between the emergence of the skull base to its bifurcation is called the facial nerve trunk. It is bounded medially by the styloid process and laterally by the mastoid tip. So if you see a styloid process during your surgery, you've already damaged it. The nerve courses in a caudo-external direction with a slight superior concavity, which I'll show you next. It then pierces and passes into the parotid gland and divides into the branches temporofacial and cervicofacial. The diameter of nerve here is very significant, almost 2 to 2.5, and it's easily identified. As you can see in this diagram, the stylomastoid foramen is here, and this in the red is the facial nerve trunk. It gives several branches. The inconsistent one first is the ansa of Heller. The posterior auricular branch is the most consistent branch after it's before the facial nerve trunk bifurcates. Then comes the nerve to the stylohyoid muscle, the nerve to the digastric muscle, the lingual branch, which is an inconsistent branch and carries fine filaments to the base of tongue for sensation. It finally divides into terminal branches. As you can see here, just at the stylomastoid foramen is the posterior auricular branch of the facial nerve. And this provides the posterior auricular muscles and the occipitalis muscle. The terminal part comes when the main bifurcation of facial nerve trunk arises, that is into the temporofacial and cervicofacial branches. This happens inside the parotid gland at the level that is, as you can see here, just posterior to the posterior border of the ramus of mandible. It then leaves in the terminal branches, then leave the parotid gland at their anteromedial surface. And these are called pes anserinus because if you see in the circle in orange, these are the goose feet and they resemble the foot of the goose as temporal, zygomatic, buccal, marginal mandibular and cervical branches. These together allow the surgeon to lift the superior portion of the parotid gland and is referred to as constituting the faciovenous plane of pate. This again is a diagram which shows the terminal branches of the facial nerve, and as you can see here, they divide into something which resemble the goose feet. There may be several variations in the division of the nerve trunk. Most commonly, the nerve trunk measures around 1 to 2 centimeters before its bifurcation. But sometimes you may have a short trunk which divides into multiple branches. So it becomes very difficult to identify the nerve in such a situation. The type 3 is the least common, where the nerve bifurcates within the stylomastoid foramen. Davis et al. Defined the variation in the branching pattern of terminal branches of facial nerve and gave 6 classification. This was later modified by Katz and Catalano, who added further subclassification and made 9 subclassification. They say that type 3 is most common, where there are interconnection in the upper branches with the buccal branch. Now, let's discuss the surgical landmark for the parotid surgery. There is tragal pointer, posterior belly of digastric muscle, the tympanomastoid suture, and retrograde dissection of the peripheral branches. So, firstly, the tragal pointer, it is the triangular medial end of the cartilaginous portion of the EAC, and this point directs towards the facial nerve downwards. The nerve is 1 centimeter medial and inferior to it. However, this tip is usually blunt and variable, and it's the least reliable landmark. Then comes the tympanomastoid fissure. See, if you see the fissure, its inferior drop-off can be identified, and the nerve lies almost 6 to 8 millimeters inferior to it. Most of the times you may not be able to see this landmark, but it is easily palpable. Then comes a very personal favorite of mine, which is the posterior belly of digastric. If you retrogradely dissect the muscle towards its attachment to the mastoid process, you'll find the nerve bisecting the angle between the mastoid tip here and its superior border. The nerve just bisects this angle. Also, if you trace the superior border of the muscle, you'll find the facial nerve 5 to 6 millimeters above it. I personally really love this landmark. Now, this is a diagram which shows its relation to the retromandibular vein. So we can also use this vein as a landmark. We can start finding the retromandibular vein and its branches in the nerve and retrogradely trace it into the substance of the gland. We will encounter the marginal mandibular and cervical branches. However, the marginal mandibular may lie lateral to the vein in some cases. Alternatively, you can find the marginal mandibular nerve just 1 centimeter and anterior and inferior to the angle of mandible and trace it retrogradely. Now, this defines some of the ways that you can identify the branches and retrogradely follow them. Frontal branch has been given by plastic surgeons as lying in the triangle defined by the line joining the inferior portion of the tragus to 2 centimeters above the eyebrow. And somewhere between this will lie the frontal branch of the facial nerve, which can be traced downwards. The zygomatic crosses the zygomatic arch just above the superior border of the parotid gland. So find the superior border of parotid gland and you'll be able to find the zygomatic. The buccal branch lies parallel to and very close to the Stenson's duct, and it is located 1 centimeters below the zygomatic arch. That is, the zygomatic arch is 1 centimeter superior to the nerve. The marginal mandibular, I already said, lies 1 centimeter anterior and inferior to it. And deep to it are the facial vessels. So you can always find the facial vessels and ligate them, and you can just turn them above and you'll protect the marginal mandibular, or you can find the nerve just superior to these two vessels. The Hayes-Martin maneuver would be taught to you by some other person when we are doing a neck dissection or a submandibular dissection. This nerve then rises upwards at about the midpoint of the body of mandible to supply the depressor anguli oris. Now, this brings us to the end of the lecture. Thanks a lot, and I now welcome any questions. Anyone with any questions? Thank you for your compliments. I would have discussed some topographical tests as well as the functions and the repaired basically gradations of the facial nerve injuries. However, the lecture was becoming very, very long. I hope we might be able to discuss this some other lecture. Uh, there is a question about how much are the chances of recovery in facial nerve reconstruction. So even in the best surgical, conditions, the recovery are only till grade 3, as you must have read about in the repaired facial nerve scoring. So we cannot get a near normal, but eye closure is usually achieved. Okay, just to explain the 7-up mnemonic, this is to understand the position of the facial nerve, just to memorize the facial nerve position at the level of the fundus. The 7-up is the drink which we have all had. So we are using this, that the nerve 7 is up and anterior. See, To remember it easily, the posterior part of the fundal segment is the vestibular area. So only the vestibular nerves will occupy the posterior part. Now to remember which lies above, the cochlear or the seventh nerve, the mnemonic is 7 up, and the seventh nerve lies antero-superiorly. So automatically the cochlear nerve will lie antero-inferiorly, and the posterior-superior area is occupied by the superior vestibular nerve, and the inferior area by the inferior vestibular nerve. Okay, there is a question, what is the maneuver of marginal mandibular nerve? So I mentioned Hayes-Martin maneuver, in which we ligate the facial artery and facial vessels when we are doing a neck dissection or a submandibular gland dissection. And then we turn the arteries, the vessels above, superiorly, to protect the marginal mandibular nerve from any injury. So this is not a way to identify the marginal mandibular nerve, but rather to protect and save it when you cannot identify it. Thank you. Okay, I will play the initial 5 to 6 slides. Those are usually nothing much. It was only a brief introduction. So So these basically give the composition of the facial nerve, where I've described about the motor and sensory root. Then I discussed about the interparenchymal elements. You can actually find these in any of the books. And then the nuclei of origin. Basically, I just wanted to show you how diverse is the supply in the single nerve of facial nerve. That is, it carries motor fibers, it carries sensory fibers, it carries taste afferents, so many things. So these are the few ones. I think most of the surgical part was covered only in the later slides, which I hope was well shared. Next question by Yuvraj is that any grading for marginal nerve paresis injury post submandibular gland. See, all the branches of the facial nerve are graded in the same pattern as the facial nerve proper. There is no individual separate grading for marginal nerve paresis. But often in the submandibular gland excision, there is minimal paresis because it is a very thin nerve and it is very susceptible to traction injury. So usually we end up having some marginal paresis in most of the cases, which recovers spontaneously in a few weeks to a few months. Any other questions? Thank you, everyone.